Welcome back everyone, Dr. Naveen here from UPSC Medical. So we will be discussing 2024 Medical Science Optional Exam Dermatology Model Answer. As we all know, the derma has been given a good weightage in paper 2 section A along with general medicine plus pediatrics. It has a weightage of 50 marks and there are around 7 topics of which each year 4 or 5 topics are frequently getting repeated. When I say this, it is important for you to understand, though the repeat percentage is 80 to 85%, if you consider topic wise repeats, it's almost 100%. Every year one or the other topic gets repeated. But a different question or a different way of asking the same question or a different clinical touch to the body of the question. So that is what they're doing. Now coming back to the topic, so what we are covering will be scabies, vitiligo, allergic contact dermatitis and lichen planus. So these are the 4 topics that will be asked in the question form. The first question, it is in the mandatory section. Okay, in a confirmed case of scabies, okay, what are the primary manifestations? So the question is about the primary manifestations of scabies and the weightage is for 5 marks. Okay, and when you have a manifestation of disease, parallelly they are asking you what is the pattern of distribution of these lesions. So what is the pattern of distribution of these lesions is another question what they are asking here. This is for 5 marks. Apart from that, the second part of the question is what is the complications which can be seen in scabies. Complications seen in scabies. Right, this is again for weightage of 5 marks. So for 5 marks of a weightage, you have to fill one side of a page in your exam. Okay, this time in the subsequent, starting from 2025 onwards, there will be a weightage pattern question booklet even for general studies also. They are not going to give you any additional. They will give you a book which contains question and space for answering. Next page there will be a question and space for answering. Within this space you have to write whatever you know. So better space management only comes with proper practice of the test series. Okay, so now if you look at this thing that what I am trying to cover, what are the primary manifestations of the scabies? Starts with a little introduction. Scabies is an infectious disease caused by Sarcoptes scabies, which is an itch mite. That means the primary manifestation of a disease is itching. So mainly the patient will complain of itch or pruritus. So when I talk about pruritus or itching, now you need to know what type of itching it is. Is it nocturnal or diurnal? Nocturnal, mainly in the night times. Any itching or any pain aggravates or is present more in the night times, and this is intense and it is not sudden in onset, it is insidious in onset. Okay, it takes around 4 to 6 weeks after infestation. It takes around 4 to 6 weeks for manifestation. Parasite is an infestation, not infection. Okay, chalo. Now parallelly along with the pruritus, if the patient starts itching and all, he will also develop eczema and he will also develop excoriations. Okay, whenever there is an itching, there will be an eczema and excoriations. We all know this. Now these are the symptoms with which patient presents. Now the classical lesion what you see in case of scabies is a burrow. So your answer is incomplete without mentioning what is a burrow is. What is a burrow? Burrow is actually a tunnel kind of thing. Okay, let me give a different color here. Okay, now you have skin here and you have an itch mite which is going inside and it is forming a burrow kind of thing. Okay, these are the burrows, the classical intraepidermal tunnels. Intraepidermal tunnels. Where are they present? They are present in the stratum corneum. This was once asked in INA-CET exam. Okay, an MCQ asked in stratum corneum. They are present in the stratum corneum. So the classical presentation of scabies is by burrows. They create an intraepidermal tunnel. Okay, and this is because of the female mite, not a male mite. It is because of a female mite. So these are snake-like. That means it is serpiginous. Okay, serpiginous, grayish lesions. They look gray in color, and they look like a thread-like elevations on the surface. Okay, when you look them on the surface, they look like a thread-like elevation. They look like a thread-like elevation. Okay, and the length is about 2 to 10 mm. The length is about 2 to 10 mm. This is what you need to know about the burrows. Now I'm taking an extra page, but you have to fit in the single page. I'm just the font is big so that you can see well in the videos. That is my intention. But when I say burrow, where are they located? The location of the burrow is important. Okay, so here comes our circle of Hebra. What you see in the image here. Circle of Hebra. I'll highlight what I'm trying to tell. So it is involving the webs of the finger. It is involving the wrist. It is involving the elbow. It is involving the axilla. It is involving the umbilicus, lower abdomen, genitalia, and the backside buttocks. If you circle it around, it gives us a picture called circle of Hebra. So these burrows are present in the circle of Hebra. The locations which are spared. This is an important area where a lot of questions come in the MCQ based exams, but not in our medical science optional. It will not involve palms, it will not involve soles, and also the neck is not involved, and also the face is not involved, and the scalp is not involved. Why areas which are not involved important? Because when you treat these cases, when you treat a case of scabies, no need to apply scabicides here. So you don't have to put the ointments or creams here. But this is not true always. In infants, even these areas are involved. Okay, in infants involved, but in adults, these areas are spared. That's why there is no need to apply scabicides. So if they ask you what are the primary manifestations of the scabies, what is the pattern of distribution of the lesions? Pattern of distribution of lesions, I am talking about circle of Hebra. The primary manifestations are these. There will be itching, scabies, and also the excoriations. The characteristic lesion is burrow, and you need to mention the locations which are involved and locations which are spared. Okay, so that will conclude a 5-mark answer. Now complications is little tricky. Okay, see what happens if you see a case of scabies. Scabies, they'll cause itching. There will be a chronic itching, but sometimes in immunocompromised individuals, this can turn into Norwegian scabies, which is a complication again. So this Norwegian scabies, the other name is crusted scabies. Crusted scabies. You see, normally in a scabitic lesion, you will see 10 to 100 mites in a normal case. But this count can range from 100 to millions. In a lesion, in a burrow, you will see 100 to millions of the mites. That's the problem. So it is very severe infestation of the Sarcoptes scabies in these cases. Okay, even dermatologists, they will be confused with some kind of dermatitis or psoriasis because the lesions are widespread. And these lesions are crusted lesions. Okay, that's why it is called as crusted scabies. Okay, done. This is the thing that you need to understand. Usually seen in immunocompromised. Apart from immunocompromised, the other risk factors, what you need to know when I talk about our scabies is that the one is immunocompromised, the second is elderly. Okay, the third is physical or mental disability. See, the problem in mentally disabled patients is they do not itch. Itching is actually protective. When you itch, the fingernails will remove the mites from the lesions. Because of the motor nerve impairment in elderly, or because they are not itching because of any physical or a mental disability, in both these scenarios, both these scenarios, what happens? The mite load will increase because they don't itch. The itching is a protective way where this is removed. So because they are not itching, the mite load will remain there. And in immunocompromised, because of the uncontrolled proliferation, our body is not acting against killing these mites. So in that sense also, the total count of the mites will increase and it will change from hundreds to millions of the mites. So this is crusted or Norwegian scabies. Apart from one complication of crusted and Norwegian scabies, there is also a condition known as nodular scabies. See, this is not about immunocompromised physical or mental impairment or motor nerve damage. This is a clinical variant where you will see a pruritic nodule which is resistant to treatment, and this involves mainly genitalia or scrotum. The same burrows will become nodule kind of lesions which are very pruritic, very resistant to treatment. They do not respond well to standard treatment protocols. So it is actually, instead of complication, I should call it as a clinical variant. For me, the complication is, if it is not responding to the treatment, it will become resistant and it will become a nodular scabies, and crusted this one. Apart from that, the other complications that you need to know about scabies are, number one, there is a chance of secondary infection. Any skin lesion, it can get secondary infections from bacteria. If it is bacteria, we call it as impetigo. Similarly, it can turn into post-streptococcal glomerulonephritis, or it can also turn into septicemia. This is one complication. Okay. Mainly the second infections is the second complication. First, we have already discussed the crusted scabies or nodular scabies. Now question number 2 for 15 marks. There are subparts to it. Okay, first let's try to look at the clinical scenario which is given here. Young female which is in her adolescence. Okay, young female who is an adult. Okay, presenting with asymptomatic, depigmented, asymptomatic, there's no symptoms like itching and all. These are depigmented, chalky white. So white colored macules. Sometimes the size is bigger so that they form patches, they coalesce and form patch, and there is no inflammation. No inflammation means any inflammatory reason for hypopigmented patch is ruled out. So the clinical scenario here is a hypopigmented patch. No inflammation means infectious causes are ruled out. Because sometimes there is a post-inflammatory hypopigmentation which develops after clearing of any other lesion. So my differential diagnosis, I'm not getting into the differential diagnosis because the weightage is only for 3 marks. If you can highlight and say that young female, asymptomatic, depigmented, they're all pointing to only one diagnosis, that is vitiligo, which is generalized vitiligo. Okay, the location of the lesion is around face and body orifices. Okay, so we can call it as an acrofacial vitiligo. We'll come back to the clinical variants we have already discussed, but for now, the clinical history, most probably diagnosis is vitiligo, that is acrofacial, which is an acquired skin disease because of the progressive melanocyte loss. The patient will have milky white macule. If you want to mention the DD also, you can mention. I have given in a model answer. I don't want to discuss in detail, but what is more important is, yes, there is a vitiligo. Apart from that, infectious causes are post-inflammatory hypopigmentation and tinea versicolor infection, which is closest to differential diagnosis. You have piebaldism also, which comes with white forelock, which should be there in your question to diagnose this white forelock. It's a congenital cause. It is seen in children. Apart from that, primary cutaneous diseases which actually cause this problem. There are systemic diseases, multiple systemic diseases that turn into the hyperpigmented. The reasons are given here. If the same question comes for 5 marks, or if they ask you discuss differential diagnosis, then it is very important for you to mention all these differential diagnosis, and for top 5 or top 6 you have to highlight the specific reasons or characteristics of these causes. Right now, coming back to our question, you know what is diagnosis? It is vitiligo. And what are the associated findings? It is very important because vitiligo is an autoimmune disease. Autoimmune. Now, within vitiligo, there is an important concept. You have segmental vitiligo and you have non-segmental vitiligo. This differentiation is important. Okay, what are the two clinical variants or types of vitiligo? You have segmental, you have non-segmental. Segmental means they are mostly unilateral. They do not cross midline. They are localized to a segment. That means they are specific to one area, or they are kind of specific to one dermatome. Okay, so there is a specific dermatomal predilection for this. Dermatomal predilection. This is not true with non-segmental. It can be bilateral. It can cross midline. So with the help of this discussion, now you know a classic difference between a segmental and a non-segmental vitiligo. Usually segmental vitiligo is early in onset age. Age-wise it is early in onset. This is little bit late, right? Now, the best advantage with segmental vitiligo is it can arrest. That means there are 5 lesions on the body. They will arrest. No new lesions will form. It is progressive. New lesions will occur throughout the life. New lesions are formed throughout life. And two important differences for exam point of view, for also parallelly preparing for MCQ based exams. One is, Koebner phenomenon is seen in psoriasis, lichen planus, and also vitiligo. Koebner phenomenon is negative in segmental vitiligo, but it is positive. Second thing is association with autoimmune diseases. Do you see any concurrent autoimmune disease in case of segmental vitiligo? No, but it is seen. That is, strong link to autoimmune diseases is characteristic of non-segmental vitiligo. So that means what are the associated findings you see in case of vitiligo? That is autoimmune diseases like Hashimoto's thyroiditis, scleroderma, rheumatoid arthritis, type 1 diabetes mellitus, psoriasis, Addison's disease, pernicious anemia, alopecia areata, SLE, hypothyroidism and celiac disease. All these are associated with vitiligo because in the question they haven't asked specifically about segmental or non-segmental. Just highlighting a point that it is more common with non-segmental vitiligo would suffice at the end. Right? Finally, how is this disease classified? The same thing. So I don't think we need to discuss this further. The classification is both segmental and non-segmental vitiligo. What is the clinical course of the disease? See, clinical types is different. Clinical variants is different. Clinical course is different. That means if you see a case of segmental vitiligo, we have already discussed vitiligo. They are unilateral lesions, do not cross midline. Okay, do not cross midline. Do not progress. That means they arrest. Okay, the lesions will arrest, and no new lesions. But problem is the current lesions which are present are resistant to treatment. You can't treat them. But if I say non-segmental vitiligo, it is bilateral, crosses midline, but new lesions will appear. But lesions respond well to treatment. So any vitiligo which is symmetrical in distribution, okay, the disease can start anywhere from face, acral or genital areas. So then there will be flares, stabilization. So there will be crest and trough kind of pattern. That is how clinical course occurs. But segmental vitiligo rapid spread, progression, arrest, the depigment branches, they are unchanged. So this differentiation is important. Okay, so this is the clinical course of this particular vitiligo. Now, next we have question number 3. Question number 3. The weightage overall is 15 marks and there are 3 subparts into it. Now let's try to highlight the clinical. See, even in the exam, try to highlight the clinical scenario, because you can, it forms a very good pillar for your answer, very strong base for your answer, okay, while writing. So the clinical scenario is young female again, young female. There is an acute inflammatory papule. What you see is a papule. Okay, the skin lesion, what you see is a papule. And also vesicles. So there is a papular or a vesicular lesion, and the location is scalp, tips of ears. That means these are contact areas. Wherever there is a contact, I think the patient is developing an acute inflammatory vesicular lesion. And triggering point, or the trigger agent, or let me call as an allergen, is a hair dye. That means my diagnosis, without even looking at the clinical question, is that it is an allergic contact dermatitis. It's as simple as that. Now, the closest to DD is, why can't it be an irritant contact dermatitis? It can't be an irritant contact dermatitis because hair dye is not an irritant, it's an allergen. It induces a type 4 or cell mediated immunity. It occurs on repeated applications. But irritant is all about, there is more burning than itching. And in irritant contact dermatitis, vesiculation is rare. And in Fitzpatrick textbook of dermatology, they have clearly mentioned any irritant contact dermatitis, the patient will know that the irritation is because of the cement or some element. So he will stop doing that itself. He won't come to a dermatologist. Most of the times when a patient comes to a dermatologist, it is mainly because of allergic contact dermatitis. Right? Now you know what is allergic contact dermatitis. Because the question weightage is 5 marks, now you can't just say that it is allergic contact dermatitis and move on. Right? Move on. So what you need to understand is that simply say that it can be because of the paraphenylene diamine or PPD, which is a component of hair dye, which is a strong sensitizer. So when repeat exposure is present because of the sensitizer, the next reaction is a little bit dangerous. Now, apart from this, the DD that you need to understand is, one thing, we have ruled out irritant contact dermatitis because absence of vesiculation is there, burning is more than itching. So see, this is how you have to write. Many of the students are confused for clinical questions how to write the differential diagnosis. They are just mentioning list. Don't just mention, at least for 2 to 3 important stuffs, highlight the negative or positive points which either dismiss your diagnosis or aid in your diagnosis. So in this scenario, absence of vesiculation, burning which is exceeding itching are characteristic of irritant contact dermatitis. Though this condition is contact dermatitis, the irritation is not there. So we have an allergic contact dermatitis as our most probable. That is probable, not confirmed, probable, because confirmed diagnosis is all sometimes clinical or sometimes we have to do biopsy and all. Now apart from that, atopic dermatitis, but skin lesions are characteristic in atopic dermatitis. Nummular dermatitis, which has coin-shaped plaques. We have seborrheic dermatitis, steatotic dermatitis, stasis dermatitis, and there is this dyshydrotic eczema, otherwise known as a variant of psoriasis called pemphigus. Okay, it also comes with vesicles, but mainly on the palms and soles, which is irrelevant here, but as a part of differential diagnosis I am mentioning it. One condition called mycosis fungoides, otherwise known as Sézary syndrome, when it becomes systemic, is important because any chronic dermatitis condition, if it is non-responding to the treatment or if it is behaving mischievously, or any psoriatic plaque which is behaving mischievously, it is important to do biopsy to identify this mycosis fungoides, which is cutaneous T-cell lymphoma. Okay, so this could be one of the rare differential diagnosis of any dermatitic lesion. So differential diagnosis of dermatitis done. What is the diagnosis in general? Because this is for 5 marks, you have to mention this. Now final justification for this question is the lesions which are mentioned here are localized to the primary site of allergen exposure, that is hair dye wherever it is. There is a prior history of sensitization present, who is a frequent user of hair dye. And yes, there is an acute reaction or vesiculation. So this is what you need to know. So this is extra points, because nowadays what I could see is whenever there is a question on a topic called dermatitis, in the syllabus it is mentioned clearly that it is allergic contact dermatitis, which is there in the syllabus. So every time I had seen in last 7-8 years, they are only asking the allergic dermatitis question in this segment, right? So you don't have to be worried about something else which is not part of the our regular part. Okay, so now coming back to what kind of future potential questions that can come. There are common hair product allergens which are important, okay, that you need to know. Okay, one is hair dye that we mentioned here, which contains paraphenyl or p-phenylindamine or p-toluidinamine sulfate azodides. We have bleaching agents like ammonium persulfate. Waving agents contain glyceryl thioglycolate. Straightening agents which are used for hair straightening, they contain sodium hydroxide. And finally, shampoos and conditioners, they also contain fragrances and preservatives which can be potential allergens. Okay, in 1 or 2 previous year questions I had seen that examiner is also asking the allergen which is present in particular stuff. So you need to have a fair idea about these allergens. So allergic contact dermatitis, the allergens are pretty important. So coming back to the diagnosis of allergic contact dermatitis, you have to take a thorough history and examination, because the next question is how can it be diagnosed, or how can you confirm the diagnosis. Any allergic contact dermatitis and per se any dermatological condition, first thing is history and physical examination. But gold standard thing that you should definitely mention in this part of the question, your answer is incomplete without this, that is skin patch test. Okay, or epicutaneous patch test is the other name. There was one previous year question wherein they asked what is the gold standard test for diagnosis of allergic contact dermatitis. It is patch testing. Now this question is again for 5 marks. Now whenever you're answering it for 5 marks, if you just mention skin patch test, you might not get full marks. Now you need to write about the procedure, how it is done, and you have to write about the interpretation. Maybe in future they will only ask elaboratively about what is the complications of skin patch test. So just for the sake of future exams, I have given you these points of complications, but for current exam they might not be relevant. Okay, they might not be relevant. Now skin patch test, we attach a patch which has common allergens on it, and the site of attachment is mostly on the back. Okay, and the results are read after 72 to 96 hours. This point is important. Okay, the results are read after 70 to 96 hours, right? And in the interpretation, it can be positive, negative, questionable, or irritant kind of thing. Okay, irritant kind of thing. So you have scoring system from +1 to +3. +1 is a weak non-vesicular response. 2+ represents strong vesicular reaction. 3+ represents any bullous or ulcerative lesion. Irritant means we'll mention it as IR. So there is no vesiculation, just irritation. Okay, that is more prominent, or burning sensation is more prominent than itching. When we do skin patch test, the problem is because we are doing this test, okay, at the site or at the location there will be some itching, irritation and all because of the tape application. In people who respond like hyper responsive patients, they might land up into post-inflammatory pigmentary changes. This can be hypo or hypopigmentation. Infections can be there, scarring can occur. Okay, sometimes even after removal of the patch, there will be persistent patch test reactions. Sometimes just for the diagnosis you are using skin patch test, but because of this test itself, the patient develops or there is a flare up of this dermatitis condition. Okay, and very rarely anaphylaxis could also be a potential possibility because you are exposing the patient to allergens, though at minute quantities they might trigger anaphylactic reaction, right? So this is second part of the question. Now third, simple, how do you treat allergic contact dermatitis? First and foremost, many of the students, when they write answer for this question, the treatment of allergic contact dermatitis, there is an allergen. Okay, first and foremost, wash the hair dye. Okay, this point should always be there. Similar thing happens in OP poisoning cases. I had seen many of the OP poisoning cases during my casualty in internship. What happens when a OP poisoning case comes? The first and foremost, we have to do desensitization. Desensitization is a topmost priority. You have to desensitize first, followed by the treatment. So in this case, because there is an itching, we can give antihistaminics, or for itching we can go for topical steroids. Okay, if the condition is little severe, we can even go for short course of oral corticosteroids. This is the usual way to go. Oral corticosteroid is prednisolone. If you can memorize, you can even memorize the dosages and all which are given in the model answer. But in general, what I'm trying to tell you is, we go after desensitization, we go for symptomatic treatment. Now, what is curative? Curative means the patient is already allergic, you cannot cure it. So prevention is more important. Okay, prevent future contact with allergens. But sometimes hair dye is of cosmetic concern, right? You can't roam with a premature grayish hair if you're actually suffering with gray hair. Now you have to use PPD free hair dyes. Okay, PPD free hair dyes. There is a new component called HPPS, that is hydroxyethyl p-phenylenediamine, which is known to be less aggressive allergen in comparison to PPD. You can use some alternative hair dyes here, right? Now, management of complications is also important. If there is secondary infection, we have to give antibiotics in these cases. That's it. So this is how you treat a case of allergic contact dermatitis. Now, final question, question number 4. It's for 10 marks. Now, almost in last 6 years, every year there was a question on lichen planus. Okay, in the lichen planus, the most common question which was asked is clinical features. This time also the same question came for 4 marks. When we are learning about clinical features with regards to lichen planus, okay, it has 6 P's. Some books mention 5 P's, some books mention 4 P's. Okay, so P means it's a polygonal lesion. P means it's a pruritic lesion. Okay, and it's a purple lesion, purple violaceous lesion, and it has plaques. Okay, this is what is given, the 4 P's in the standard books. Okay, don't worry about the rest, but you have to start answer by mentioning pruritic, polygonal, violaceous papules and plaques. Okay, purple, papules and plaques, right? Violaceous, violet or purple, they look similar. Now apart from this, when they ask you about clinical features, not only skin is affected, yes, there is lichenoid lesions on the skin. Apart from that, it also affects scalp. So on the scalp, the condition is known as lichen planopilaris. So one of the cause of scarring alopecia is this. Okay, lichen planus causes scarring type of alopecia. Another condition where there is scarring but there is no swelling and inflammation, we call this condition as pseudopelade of Brock. Okay, so if scalp and follicles get affected in lichen planus, this is what happens. You have lichen planus, lichen planopilaris, and you also have pseudopelade of Brock, right? And one more area where questions might be expected in the future, because nail changes in psoriasis has already been asked recently. Now in future they might ask nail changes in lichen planus, because lichen planus is examiner's favorite topic. Now there is onycholysis, that means the nail comes out. If this is nail, okay, nail comes out of the nail bed. Or one more condition, very important MCQ, in many of the MCQ exams they'll ask you, pterygium of the nail. Nail plate is destroyed. So this will produce pterygium of the nail, classically seen in lichen planus. One more condition is anonychia, or one more nail change is anonychia. That means the nail completely disappears. Complete disappearance of the nail is anonychia. But the earliest change, the first thing that happens is thinning of nail plate. So thinning of nail plate, appearance of grooves and ridges, because they will ask this question for 5 marks. What are the nail changes in lichen planus? Can be expected future question. So first thing is thinning of nail plates. There may be grooves and ridges. The patient will have onycholysis, pterygium and anonychia. Right? Even apart from skin, apart from nails, apart from scalp or hair follicles, even mucous membranes are affected. So that means oral cavity is the most common area where lichen planus develops. So inside the cheeks and tongues there is painful erosions and ulcers will be seen. Okay, so there is Wickham striae, that means white streaks in lacy or fern pattern are seen in case of lichen planus. Right, done. Now the other question here is, we're done with the 4 marker one. Okay, next thing is name the disease that is prototype of Lichenoid reaction. Simple question. They're asking you for 6 marks. For the first 3 marks, what is a Lichenoid reaction? Suddenly this question has confused many of the serious aspirants, because we always learn about lichen planus, but we don't know what is a Lichenoid reaction. See, the term Lichenoid means it is derived from lichen. This lichen is all about an algae. Okay, algae. Lichen means an algae. Lichenoid reaction or lichenoid eruption means the lesions which are similar to lichen planus. So in lichen planus we have purple, we have polygonal lesions. Okay, so similar to that, in any other condition like usage of drugs, thiazides, antimalarials, quinidine, beta blockers, TNF inhibitors, anti-PD1, PD-L1 antibodies, ACE inhibitors, and also in graft versus host disease, these kind of Lichenoid reactions or Lichenoid eruptions can be seen. Lichenoid reactions or Lichenoid eruptions can be seen. So that is what you need to know about Lichenoid. Lichenoid is a term which resembles lichen. Lichen is a hybrid algae. Okay, it's a hybrid algae, and any lesions which are like lichen planus, we call it as a lichenoid eruption. And apart from lichen planus, apart from graft versus host disease, the leading cause of lichenoid eruptions are drugs. So among these drugs we have thiazides, antimalarials, quinidine, beta blockers, TNF alpha blockers and ACE inhibitor. Okay, if you remember 3 to 4 drugs, it's well and good. Okay, little bit offbeat question this one. What is lichenoid reaction? Apart from that, name the disease that is prototype. Simple, you have to mention lichen planus. Just mentioning lichen planus, the examiner should give you 2 out of 3 or 2.5 out of 3. These are all the extensions so that you will be able to fill up a page and get those 5 marks. Now this will conclude our discussion on dermatology, a 50 mark weightage question. Dermatology is a high yield subject because every time the same topics and same questions they get repeated, and it's a scoring way, right? It's a scoring subject.